or situation and how our body can manage them, and we call it compensation or compensatory effect. First of all, again, I have a case here. Please interpret the data and given the type of acid base disturbance. The blood pH is 7.12. Partial pressure of CO2 is 80. Plasma bicarbonate is 26. And acid carbonic is 20. What are the causes for the condition? Just remember that pH, PCO2, and bicarbonate.
Is that normal?
Sure.
Normally?
We will check them. We should know, and then just remember that we will check. You actually know about the acid and bases. The acid are those which they are capable to donate proton, and the base they are those which they can accept the proton. For example, here we have a acid carbonate, acid chloride, and actually ammonia and bicarbonate. Here you can see they release the proton, and here they receive a proton. We have a two term, weak and strong, acid and base. Those acid or base, they are known as a strong, they completely dissociate, okay? They separated to H plus and Cl negative. So we call acid chloride is a strong acid. And for acid carbonate, if you look at that, some part of this dissociate to the bicarbonate or H plus, and some part of the reaction will go back. So, and we have a balance between the production of base and production of acid. And this is known as a partial separation. So, when we say the acid is a weak or base is a weak, it means partial part of them are going to separate. Here we have a formula which is called A, or actually dissociation constant is equal to the concentration of these two products by the precursor. The pH at which the acid is half ionized is known as a pKa, which for a strong acid the pK is low, for weak the pK is so high. And here you know about the pH somehow regular to the related to the pKa, but here we have a definition: pH is equal to minus log of concentration of the proton, and they are actually vice versa with the OH. For example, when we say the pH is a neutral, the log of proton is -7, and pH is 7. Also, pOH is a 7. So when the concentration of the hydrogen is increased, the pH is decreased. H plus concentration increasing, pH is decreasing. You learned in the first semester about the Henderson and Hasselbalch equation, which pH is equal to pKa plus log base to the acid. And the application of this equation is about to the when we are going to use to solvent, how much of acid or base we have to use, and also for disturbance of acid and base in the clinic, also we can use Henderson and Hasselbalch. So related to pH in our body, the pH normally is 7 point how much? 4. 7.4 is the normal pH. Actually, it can start from 7.38, 35 to 7.43, 42. But the normal is 7.4. When the pH is changed, decreased or increased, the function of enzyme, protein, reaction, metabolism, and oxidation will change. So our body do a lot of function to maintain the pH at a normal value. Daily we use a lot of precursor which they can lead to the increasing or decreasing pH. For example, we ate a lot of acid, or we produce in our body, like lactic acid, pyruvic acid, oxalic acid, or other acids. So this acid decrease the pH and lead to the acidification of the plasma. And otherwise, sometimes we use this acid and increase the pH and lead to the alkalization of the plasma. In both situations, our body have a lot of regulation to maintain the pH, to return the pH to the normal value. One system, the first system, they are known as a buffer. You learn buffer, what they were.
There are solutions which stop the pH from changing too much.
They have with acids as bases and with bases as acids.
Exactly. They have an acid and conjugated base. Okay? When, for example, here is an acetic acid and NaOH. We have a two side. For example, also here. When we are going to have a high hydrogen, they will go to acidic part by using this hydrogen, and otherwise. We have a three main buffer system in our body. Bicarbonate buffer, which is the main buffer in blood. We have actually not acetic acid. We have a phosphate buffer in our body and protein buffer. These three are the main buffer in our body. But let's talk about them. Related to effective range of action of buffer is a both positive one and negative one. Actually, the effective range of buffer is a 1 pH unit, higher or lower than the pKa. When pH is equal to pKa, this buffer has the highest capacity to prevent changing in the pH. If you remember from the first semester in biochemistry 1, the first practical was about titration. In titration, when you add a base to the acid, you didn't see any change till you increase the amount. After that, those parts you didn't see the change. It's known as a buffering region. At that buffering region, by adding base, the buffer resistant against the changing in pH. But if you increase too much, the buffer cannot do anything. So this range, pH plus 1 or negative 1, is the highest capacity actually or effective range of buffer. So daily, actually we produce 40 to 80 nanomole of hydrogen for 24 hours. And actually it can be incomplete oxidation of energy substrate like lactic acid by glycolysis, oxalic acid by keto acid, or from triglyceride. And actually sometimes we use by gluconeogenesis from lactate or oxidation of ketone. You learned them in the previous semester. So sometimes we produce this hydrogen, sometimes we use them. And all the time we have to return the pH to the normal value. One of them, the first layer of difference is a buffer, bicarbonate, phosphate, and protein. And also we have a respiratory and renal regulation. Just I wanted to have a brief review, you know about them, and about renal I will discuss in details. So here in a buffering of hydrogen ion, you know in metabolism what's happening in our body during the metabolism. During the metabolism, we digest food and actually use glucose, amino acid, and fatty acid as a source of energy. And finally, we produce what? Energy and CO2. Yeah, energy is 80. We convert them to the CO2. Okay. CO2 is produced in high amount in our tissue. Then this CO2, in our tissue, what we have? H2, water. Water is present everywhere, places. So these two together, they convert to the H2O CO3, acid carbonic acid, bicarbonic acid. You know about it. And finally, is convert to the bicarbonate and
H positive.
exactly H positive. So all the time CO2 is equal to the H plus or is equal to the acid carbonate or bicarbonate, doesn't matter. When we say we have an oxidation or metabolism in the tissue, we create an H plus, H positive. And it means the pH will decrease in the tissue. So what's happened for this H plus? We have to use it. And also we should to excrete this CO2. Here in the tissue, this bicarbonate actually is go outside the RBC and H plus is binded to the hemoglobin. When hemoglobin release O2, H plus is released. Some part of bicarbonate also bind to the hemoglobin. Actually 70% of CO2 go outside by bicarbonate, 23 by hemoglobin, and 7% as a dissolved CO2 we remove from our body. And hemoglobin bind to the CO2 of the bicarbonate. Okay, 32% bind to the CO2. And color is coming inside the cell, in the tissue. It will be sent to the lung. In the lung, this bicarbonate come back to the inside the cell, and also CO2 will release, and CO2 dissolve with excrete. This bicarbonate bind to this H plus, hemoglobin bind to the O2. H plus will release, it's convert to the H2CO3, and it's actually convert to CO2 and H2O, and CO2 will excrete now. So this H plus by bicarbonate converted to acid carbonate, and other way here is happen, which they are known as a bicarbonate buffer system in our body. This system is responsible for 65% of capacity of plasma buffering and 40% of whole body buffering. Because it's open system, and by the kidney bicarbonate, and by actually lung the CO2 and bicarbonate and H plus can be regulated, it's so important in our body. It's an open system. And the PK is not so good. We have a 3 factor for a good buffer. One of them is a PK if it should be, or if it be near to pH. In our body is so. Our pH is 7.4, but the PK is 6.1. It's somehow low. The second one is the concentration of acid and base. If they be equal, is so good. But here, the acid, for example, acid carbonic is 2 or less than 2, 1.2. H2CO3 is 1.2, and bicarbonate is equal to 24, near to 22. Also is not good. But because it's an open system, and by kidney and lung we can handle and manage it, is very, very important. The second buffer system is a bone phosphate buffer system, which is the main buffer in intracellular. Because pK is 6.8, is similar to the pH
Of the
it's so
blood.
good and has a good capacity inside the cell. And pK value is near to the physiological pH, is an effective buffer in the inside the cell. Here we have a three actually way for buffer system, but I didn't bring them. And related to protein, if you remember again from the first semester, we have an amino acid with the name is histidine. Histidine gives them the capacity of the buffering, which this imidazole group. The pK is 6.1, and the protein also are good buffer intracellular, not outside in ECL. And finally, we have a hemoglobin buffer. As you saw inside the RBC, it can receive H plus and also in the lung release them. It's bound to the hemoglobin. Hemoglobin is the main buffer in RBC. In bicarbonate system, pH is equal to pK plus low bicarbonate to acid carbonate. pK is 6.1. The concentration is 24, 1 point. And actually the pH is 7.4, the normal pH. For acid phosphorate, if you look at that, we have a three kind of separation or dissociation. When it has a 3, when it has a 2, when it has a 1 hydrogen. And if you look at the pK, it's 1.9, 12, and 6. These two pK are not important in our body because in our body we don't have this acidity or this basic condition. It's similar to our pH, and this 2 capacity H2PO4 negative is important in our body. Related to the respiratory, I told you actually, but I don't know what's happened here for this figure. Is inside the RBC what's happening? Red blood cell. CO2 is produced by H2 combined together, H2CO3, H2CO3, is produced, and actually bicarbonate go outside the red blood cell, chloride is coming, and H plus bind to the hemoglobin. It's happening in the tissue. In the lung, hemoglobin bind to the O2, H plus is released, H plus by bicarbonate, which is coming inside the cell. Combined together, H2CO3 is produced, H2 and CO2 will excrete from our body. But the buffer, actually, they act immediately at the second or minutes. The second one is related to the lung and rate of ventilation. Okay? But the main part is regulation by the kidney. By the kidney, we have a different mechanism. One of them is excretion of H positive. Then we can reabsorb the bicarbonate. We call it recovery of bicarbonate. We can excretion of titrable acid or net acid excretion, and also we can excrete the ammonium ion. What they are? Let's look at the, actually I will pass through this net acid excretion. Here is important for us. Actually is that I mentioned, just I wanted to follow it and to see what's happening here. Is RBC, red blood cell. CO2 is produced in cellular metabolism. CO2 by hemoglobin
Excuse me,
compound.
not pointing.
Doesn't matter because just when I wanted to zoom it, you can.
اصلا که بیرون بشین میشه
What?
اصلا بیرون بشین میشه
آره دیگه ولی من میخوام زوم کنم.
درست. آره.
Here, by my finger I can show. This
This one is very
CO2.
important.
Okay. 23% just combined by hemoglobin. 7% dissolved CO2. But 70% is combined bicarbonic acid to bicarbonate, and bicarbonate will send out, and hemoglobin binds to the H+ in the tissue, blood plus. But then in the lung, what's happened? First of all, these bicarbonate in plasma come into the RBC and polarized go outside. This dissolved CO2 will excrete. This CO2 which binded to the hemoglobin also will release and excrete. This H+ from hemoglobin is released by this bicarbonate bind together. Finally, CO2 is produced and carbon dioxide is transported. But in the kidney, what's happened here? In the proximal tubule is a plasma, and here is a tubular or tubular tubule. What's happened here? In the proximal tubule, we combine CO2 and H2O together. It's converted to the acid carbonic and then H+ and bicarbonate. This H+ can excreted by the hydrogen ion exchanger, and sodium is reacted. So we can excrete H+, and also we can recover bicarbonate. Okay? Bicarbonate is recovered, or alkali is recovered. Again, you can see in this slide. In the renal hydrogen ion excretion, bicarbonate and sodium are filtrated by bromine. Then this sodium is reabsorbed, this H+ is excreted. They combine together, bicarbonate, H2 and CO2. They combine together, bicarbonate, H+ bicarbonate, bicarbonate will reabsorb. So this bicarbonate which filtered finally reabsorb, and CO and H+ is excreted. So we call it recovery of bicarbonate in the actually liver. Related to potassium, you learned in the previous session, when there is an increase in H+, extracellular fluid in ECF or plasma, it's made to exchange of H positive with K positive. And the net effect is lead to the what?
Hyperkalemia.
Hyperkalemia. Exactly. In general, acute acidosis is actually associated or correlated with hyperkalemia, and acute alkalosis with hypokalemia. In renal tubular acidosis, because we cannot excrete hydrogen ion, also we can't reabsorb potassium. Our potassium will excrete in the urine and lead to the hypokalemia. Okay, it was just the beginning and general information. But right now is our lesson. We have a term which is known as an ABG, arterial blood gas. Arterial blood gas analyzer, blood gas measure. We have two type of actually instrument. Some of them they are portable, and you will go to the hospital, to the bed, and you take a blood, immediately you will analyze. Sometimes in the lab you have a big instrument and you have to bring the sample from patient to the lab. It's so important how to take the sample and how to transport it. you should transport on ice, because you need to measure the O2, hydrogen, and CO2. First of all, why we do ABG analysis? When we are going to do ABG analysis, we are going to evaluate or check severe breathing problem in those patients with COPD or chronic obstructive pulmonary disease, or those people with cystic fibrosis or lung disease. So for all kind of respiratory or lung disease, we need to check age. When we are going to treatment, lung disease is work or not, we are going to follow the treatment. Then when we are going to find out the patient needs extra oxygen or actually mechanical ventilation or not, especially during the corona pandemic, we should understood this patient need mechanical ventilation or doesn't need. By ABG analysis we can find out. Find out when we actually give oxygen to some person, is it the correct amount of oxygen or need more or need low? By actually knowing the oxygen in their blood. And for measuring the acid-base level on the people which they have a heart failure, they have a kidney failure, they have an uncontrolled diabetes, a sleep disorder, severe infection after drug overdose. For this reason, we need to do ABG. So ABG, from the name, is completely clear. We need to take blood from the artery, not from the
Vein.
vein. Why?
Because the gases in the vein are different. It will have
Which gases?
oxygen mainly and carbon dioxide.
Exactly, thank you. We will measure actually some factors. Those are important. pH, PCO2, PO2. They are the most important factors. The pH between vein and artery doesn't actually different. It's less than 0.1 different between vein and artery. CO2 also is not so much different, less than 20%. But oxygen more than 60%, 56%, we have differences between artery and vein. For this reason, we need to take blood from the artery. And those nurse or actually lab medicine worker, which they are coming to take, they should know about the artery, radial artery especially, and actually the position of the artery. And it's so painful when you take blood from artery in comparison to vein. So we will measure PO2, PCO2, and H+. And for this reason, they lead to the increase or decrease. For example, PCO2, when we have a peripheral vasodilation, headache, or actually coma, drowsiness, we have increased in PCO2. And decreased in tetany, headache, muscle cramp, and dizziness. Or related to H+ also is similar. But let's to have a look at the clinical and laboratory assessment of hydrogen ion status. We use the two units. One of them is a millimeter of mercury. One of them is a kilopascal in some references. When you solve kilopascal, if you multiply by 7.5 is equal to millimeter of mercury. But millimeter of mercury routinely is more common in comparison to the kilopascal. So as I told you, the differences between H+ is less than 2 nanomole between vein and artery. And for PCO2 is less than 1 kilopascal is equal to 7.5 millimeter of mercury. but for oxygen is equal to 8 kilopascal, is near to 60 millimeter of mercury. So we have to have an artery blood, not venous blood. So, related to the number you ask, the normal pH is 7.4. You should know that. And the hydrogen ion concentration is equal to 40 nanomole. 40 nanomole, pH is 7.4. But routinely we use pH instead of hydrogen concentration. The pH can be actually from 7.38 to 7.42. But routinely is on 7.4. We have a two situation, acidosis and alkalosis. Acidosis means pH is below 7.3 and alkalosis is more than 7.42. Here, this can occur when pH is below 7 and this can occur when pH is above 7.6. So from 7 and 7.6, just 0.2 if your pH decrease or increase lead to this. You can find out it's so important for our life to regulate the acid-base balance. The disturbance of an acid-base, they are known as acidosis, falling pH, alkalosis, rising pH. Because as you learned, we have a two parts, kidney and lung. We have a two kind of acidosis and alkalosis. Respiratory or metabolic or non-respiratory we call it. Metabolic or non-respiratory. So we have a four main conditions. Respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis. This session is about these four conditions. And I will give you a question about this more than other. As you learn, in respiratory acidosis, we have an excess of carbonic acid. It means CO2 is increasing in our body. We can't excrete CO2. In metabolic acidosis, we have a deficient in bicarbonate. And vice versa for alkalosis. In respiratory alkalosis, we have a deficient in carbonic acid. We excrete too much CO2. And metabolic alkalosis, we have an excess in bicarbonate. We can't excrete bicarbonate through the kidney. So this process, actually, you learn about that in the next slide. I will do it again. This is the blood pH and Henderson-Hasselbalch equation based on this formula. pH equal pico log of bicarbonate CO2. CO2 is acid carbonate. Okay? And you can learn when bicarbonate is increased, okay, bicarbonate increase, pH also is
Increases.
when CO2 is decreased, again is increased. Just if you remember these two or one of them, the other completely are clear. You don't need to memorize all of them. Just one situation you know, the other are in acidosis. If bicarbonate decrease, pH also decrease. If CO2 increase, pH also decrease. So, I will talk about it again and again, and you can find what's happening. You need to do these 6 steps to evaluate the ABT analysis result. First, is the pH is normal and acidic A, or alkalotic or basic B? Because we are going to distinguish between acidic and alkalic, we use B for basic instead of alkalic. Then, Is the PCO2 is normal or not? 3. Is the bicarbonate is normal or no? 4. Match the PCO2 and bicarbonate with pH. For example, we know when we have an acidic condition, in the acidic condition, for example, metabolic acidosis. In metabolic acidosis, bicarbonate is decreased. So we have to know if it's metabolic acidosis, bicarbonate should be decreased. If we saw we have an acidic and bicarbonate is increased also, we should to interpret. I will bring some example and you can understand what I'm saying. So we have an acidic, basic, and actually normal situation. Sometimes my slide actually completely destroyed. I don't know what's happened for this slide. And I didn't bring my laptop also. But doesn't matter.
We'll reschedule. No problem.